Thank you for joining us. Today, we'll be discussing healthcare transformation, the shift from volume to value, and specifically, finding the upside opportunities so that healthcare organizations can survive the sea of change under the Affordable Health Care Act. You are the national practice healthcare leader, and a lot has changed. So can you give us a 35,000-foot view and tell us the current trend in healthcare?
Absolutely. I'm going to go through a couple of quick slides here. First, I'm going to address the recent growth of accountable care organizations. There are roughly 626 ACOs today, but you've seen one. They break out into three broad categories. About 329 of them participate only in government contracts. Roughly 210 participate in commercial contracts, and about 74 participate in both. We have 13 ACOs that are still undeclared, and actually just hot off the press on Tuesday, Sharp announced that they were pulling out of the Pioneer ACO status, and that makes it 10 that have done so, and some of them have declared a transition into a Medicare Shared Savings Program as opposed to a Pioneer. We've seen roughly 51% of those ACOs are physician-led, but the trend seems to be tapping out. It seems to be plateauing because of the trailblazers have already made their move. And I think another inhibiting factor of additional growth is the fact there's no preeminent model that's emerged. So we'll go to the next slide. This just simply affirms the fact that most of the growth was in 2012 for both the number of ACOs and the attributed populations. Right now we have, from a non-Medicare patient population attributed to or participating in CMS ACOs, non-Medicare patients participating in CMS ACOs, roughly 33 million. Non-Medicare patients in commercial ACOs, roughly 9 to 16 million. That number is a little hard to track because it's hard to get that information from the payers, frankly. The Medicare beneficiaries in CMS ACOs are right now about 5.3 to 4 million. So that foots to anywhere from 46 to 52 million Americans are touching accountable care organizations right now. It's projected that in 2017, that number will grow to about 130 million. Now I want to get to the slide that's on the screen. This is an interesting slide in that it talks about, what this is trying to communicate is the four primary paths that employers have to choose from. They can either migrate into the exchange, facilitate subsidies for their employees to migrate into the public exchanges. Right now that's tracking at about 26%. Employers can exit completely and pay the fine. That's tracking at about 6%. They can stay and continue to manage medical trend the way they've been managing it in the past, and that's the lowest category at 5%. And then we have this other interesting category called house money, house rules, and those are the large employers that are hunkering down in their ERISA self-funded employee benefit plans, but they're basically adopting the philosophy of, this is my money, so you're going to play by my rules. So this is where all the commercial payment transformation is coming from. Large employers that are adopting global bundles, moving towards population management, shifting risk to the payer directly or to the provider directly or through a payer. So this is, I think, what's driving what we know this decision from the Fortune 1000, principally the Fortune 500, and actually being driven primarily by the Fortune 100, is the fact that they are moving in this direction, house money, house rules, and really pushing the envelope as it relates to commercial payment transformation. This is probably the most important slide. So we see, if you take over the next 10 years, if you map out provider revenue over the next 10 years, what is that going to look like, and how are they going to migrate and adopt to these payment transformation models? And they're really going to fall into four broad categories. Providers are either going to be volume oriented and hanging on to fee-for-service. That's where over 50% or greater of their revenue is coming from fee-for-service contracts. And there's still vestiges of fee-for-service that will remain, principally in the South and ironically in the Northeast. We've got destination acute care providers, and those are the providers that don't have all of the ambulatory or primary care assets on the front end to be an effective population manager. So they're focusing on what they do best clinically, whether it's cardiac, whether it's OB. I know there's a large employer that does all their pelvic organ prolapse procedures at Geisinger Clinic, for example, and they actually warrant that procedure. So they'll fall into that category. The third category being population managers. Those are the entities that actually have either owned or appropriate affiliations with primary care assets, ambulatory assets, and post-acute assets to be able to effectively manage those populations. And those will be the players that roughly participate in north of 60% of their total payer mix, in the commercial segment being driven by total cost of care models. And then you have the fourth, which is really kind of the schizophrenic category, and that is those providers that are trying to live in both worlds, trying to live in the fee-for-service world while they attempt to participate in all of these other different payment transformation models that are emerging, which will be very difficult. Each one of these four categories require its own unique model, its own unique form of clinical and operational transformation. That's it.
Well, they're very interesting because you had outlined the four different categories, and it brings to mind what's really going to survive all of this. It's almost, the analogy is the healthcare Hunger Games, so to speak. Do you have any forecasting as to whether or not you see great promise in innovative contracts and different payment models?
Yeah, that's a very good question, and I think one that it's hard to peg exactly how those four categories are going to be distributed. How is that distribution going to pan out? And I think it's those, and there's a point I want to raise later in the webcast, but it really is a function of whether the institution has the ability to fundamentally clinically manage populations outside of their own clinical environment. Do you have the assets necessary to be an effective population manager, or do you have enough clinical integration in certain clinical areas that will allow you to function as a clinical destination player? Focus just on clinical bundles as opposed to the overall population.
Now you mentioned the clinical integration, so I'm going to pose the next question to you, Dr. Billingham. What does clinical integration mean? Are we talking managed care? There's different definitions, and I don't know what an integrated delivery program or integrated delivery network is as opposed to the words that are being tossed around today.
I'm not sure any of us do. It's a very good and it's a very hard question, to be honest. If this is managed care, it's managed care on steroids.
Absolutely.
I think the three of us would all agree that this time around it really does feel different for two fundamental reasons. Ron just went through how the delivery system itself has changed, but also the reimbursement has changed as well. And those two are going to be big drivers in what we're going to talk about over the next hour. Keep in mind, if you were a successful healthcare CEO in the traditional model, how did you make money or have a profitable business? You admitted patients to the hospital, you drove ancillary services, and you did more procedures. Now that's all been turned upside down. And Ron again alluded to the fact that different players are going to end up in different spots depending upon their ability and their resources to deliver that care. Not everybody's going to be capable of delivering population-based management. So I kind of think about it, we have all watched and continue to watch land grabs where people are purchasing smaller healthcare systems or large medical groups. And one of the problems with that in the delivery integrated model is what I call the hub and spoke problem, which means you may have best practices, great, guidelines, but do you know that that's happening 60 miles down the road? So just because we have consolidation doesn't necessarily mean we're going to get to continuity of the delivery of care. So in my mind, I see three different kind of venues. One is this development, lots in the press about skinny networks, which is the ability to try and control costs, control the providers, steer patients in so that you can really start to collect data and have meaningful use on that. The other is for people that can't do all that, they're forming collaboratives. And Ron, I know you and I have talked about this before, where smaller healthcare systems getting together and sharing data and helping each other out. And the last one I would call the 3 Ps. Hospitals and healthcare systems have traditionally, with clinicians, been the providers. And the game now in terms of your integrated model is, can you control the dollars and the data to deliver population-based medicine? And Ron said it well, and that's what I call the 3 Ps. No longer will it be okay to just be the provider. They also want to be the payer. They're forming their own payment systems, and we're going to talk about ACOs. But at the end of the result is, can I provide excellent population-based medicine?
So I'm hearing the terms population health, integrated healthcare delivery. Is that the panacea to resolving the healthcare transformation? or just one component of it, one small component?
I think it is going to be one component. I think it will depend on, we've got kind of a dirty little secret. We do have an oversupply of beds in this country. And I'm seeing scenarios play out where as little as 2 years ago, there were M&A activity that one player may have backed away from the table. And now 2 years later, that entity that backed away is begging to be back at the table. And the potential buyer is looking at the demographics of that particular geography and saying, we're not really sure that a hospital even needs to be in that county. So that's going to play out across the country. Politically is a challenge there. Hard for a governor to run on a platform that I successfully closed 25 hospitals in my state. So that's going to be a challenge. But to the tune of about 700 facilities that are going to change, either go away or are going to become ambulatory surgery centers or some other alternative care, lower care environment. So I think it all depends on whether, the recurring theme for me is, does the system have the DNA within it to be an effective population manager, or are they going to default to being clinically specific and embrace the bundles?